Good afternoon, everybody. Welcome to I think it's our fourth annual STD informatics webinar. Today's topic is electronic case reporting. We're really excited that you're here. I think this is a really great, really timely topic, and I think you're going to get a lot of good information. So without further ado, and again, Robin, if you could monitor the participants coming in. My name is Charlie Rabins. I am a capacity building and technical assistant consultant with the National Coalition of STD Directors. I'm going to be co-facilitating the meeting with my colleague, Robin Hennessy from the CDC Division of STD Prevention, Surveillance, and Data Science Branch. And we've been coordinating informatic webinars for about 2 years, and we've been running STD surveillance users groups probably for 6 or 8 years. Not everybody's been on for that long, but just to give you an idea of kind of what we've been doing. Kind of while we're waiting to get everybody in, a quick poll question to see whether you've been on any kind of informatics webinars with us before. So if you could just take a second and just tell us whether this is your first informatics webinar or not. And we're not giving you any choice for not applicable or it doesn't apply, so it's either yes or no. We'll hold this open for a minute. So we got a few more people that haven't answered. Again, we'll hold it open for about another minute. And I'm going to end the poll. And look at the results. So it looks like about half of you are new, which is great. And the other half is returning, so that's a good sign as well. So welcome to our newer participants, and thank you for those who are returning. And we're going to go through some logistics in a second. So let me hide this. So a few housekeeping issues. First of all, if you need to get a hold of any of the facilitators or presenters, please use the chat function to talk with us or ask for help. Also use the, there's a question and answer function. If not, use the chat function. If you have any questions to ask for presenters, and we hope to have some time to take some questions immediately after each of the 2 main sets of presentations, but it does help us if you put the questions in chat and then somebody can be looking at them during the presentation and be ready to answer. So that would really be help. We are using the internet, and so if for some reason my internet as the host goes down, hopefully our other co-hosts will be able to continue, but if for some reason we lose connection, just stay online if you can, and give us a minute to get back on and reconnect video and audio. So as long as you're up, just stay on, don't bother to get off and stuff. Again, I didn't have a chance to put today's slides up on the webinar chat function, but we are going to be posting a copy of the slides as well as a recording of this webinar on the NCSD website, and I'm going to let you know in a couple minutes of where that is. So you will have, total access to our slides for any of your colleagues that weren't able to attend today's great meeting, we hope. You'll be able to direct them to the recording. So, or if there's something you want to recheck or whatever later. Okay. So our agenda, it is pretty packed today, is I'm going to do a quick update from NCSD. Robin's going to give a little bit of update from the STD division. And then our main section is presentation on electronic case reporting and an overview from CDC. And then the New York City folks are going to give us sort of a project overview of their work with electronic case reporting. So that is it in a nutshell. I think so I'm going to go ahead and kind of start with our welcome. This is a picture probably from the 40s or 50s, maybe even the 60s, of what it used to look like for STD registries and case reporting. And Actually, I'll date myself. I started in the 1970s. And we used to have this huge room that had all these, case files. If you worked in any kind of a city or a state health department of any size, you had just had rooms full of, um, you know, hand paper case reporting, and everything was, laboratories and healthcare providers used to send us all paper report forms, and it was just really laborious to sort of try to manage case reporting. And then also, not only that, is you got the paper form, and then to try to manipulate that data and do some data analysis was extremely difficult, really, until computers started coming out. Probably, mainframe computers in the late 70s, early 80s, and then PCs probably in the mid 80s, early 90s. So, prior to then, case reporting and analysis and doing surveillance was extremely difficult, especially with, STDs, because traditionally STDs, probably up until COVID, were the #1 most frequently reported sexually transmitted disease. So that's why I think today's topic is really timely. Just a couple of highlights from NCSD. I think many of you are members, but if you're not, a couple of things on our website, and here's the link to get into our website. We have created a monkeypox, what we call our command center, where we have all sorts of resources linked to the CDC website and all sorts of other websites, that provide policies and procedures, any kind of news about monkeypox. We actually created this as soon as the monkeypox sort of came out. So we've been really trying to stay on top of monkeypox. We've also been extremely proactive in working with Congress and the administration to try to get more resources for state and local health departments and community-based organizations so they could do monkeypox testing and vaccination and surveillance and those kinds of things. So things look up as far as getting some additional monies out. I think hopefully, I think today there was going to be an announcement that monkeypox is going to be made a disease of concern, emergency status. So I think we're really glad of our work, but I think, again, this is a great resource if you're looking for monkeypox information. Our site, along with other sites, I think could really help you out as far as providing you with some really great information. If you aren't getting, NCSD puts out a weekly email update that provides information on upcoming events. We have links to articles in the news about STDs. We have a job posting bureau. We talk about any advocacy work at the federal or state level to get more money or changes in policy. So if you're not getting one of our weekly email updates, then you could just go right into your email box. Go ahead and go to the NCSD website, which I'm going to give you in a second, and join as a member, and you automatically get the weekly email update. One of the things that we've recently done is, and we're actually in the process of doing this now, is those of you who are NCSD members, we've created a separate sort of what we call My NCSD page, where you have to be an NCSD member, which is free. And once you're a member, you have access to this community where you can talk to your colleagues, and it's sort of roped off. The general public can't get to it, but it's a really great place to ask questions of your colleagues. You can post resources and share your expertise with other people. So I'm going to, next couple slides is just to give you an idea of sort of how to create and access the site. And we're, as part of the user groups, we used to run Slack channels where we had a Slack channel for the PRISM, Maven, and NBS user groups, but we didn't really have one for people that are interested in STD informatics and that maybe didn't use one of those 3 sites. So we're going to be sort of doing away with our Slack sites, and this My NCSD, we've actually created a surveillance and informatics community as a way where people can, again, post resources, ask questions, get help from either NCSD, CDC, or their peers. So basically, you have to go to the NCSD website, and here's the URL to do that. And again, we'll make the slides available. You sign up as a member, you should get a notice of how to join My NCSD, and I'll also be sending out an email probably next week with more explicit instructions to everybody who is on this webinar and actually everybody who's on our mailing list for surveillance and informatics. And I would highly encourage you to join my NCSD and then join. Basically, when you get, you go to a landing page that says welcome to my NCSD, where the red arrow is, you go to a sign up. And then once you're in, everybody is really part of this general forum. And then we have some specialty sections. If you're doing DIS work or interested in DIS work, you can join our DIS community. You can join our Clinic Plus community, which is for sexual health clinics. And then we've recently just created this STD surveillance and informatics community. It's a little bit sparse right now. We're just starting to add resources to it. I've loaded, I think, recordings of the first 3 informatics webinars, including their slides. And just to give you an example, this is from one of the other communities, but if you look at this top one, I know it's a little bit hard to read, but somebody from our NCSD staff, says CDC has released a new fact sheet covering social gatherings, safer sex, and monkeypox, and provided a link to probably the CDC website. So, again, a great place to share resources. And this is a good example of once you're a member of this, you can post a question. So somebody wrote, are any STD clinics or clinic partners in the community, if they could share slides for an orthopox, monkeypox, Jenios vaccination workflow training? They're looking for a quick presentation. So instead of having to come up for a presentation from scratch, this is a great way that you can ask questions or share resources that have been helpful. So those are a couple things that we wanted to alert you to from NCSD. If you have any questions, and feel free to email me. My email should be at the end of the session presentation. And again, or from the email that had the registration link. So we have 2 speakers from CDC. One is Alejandro Perez, is a health scientist at CDC's Division of STD Prevention, and has been in the position since 2018 and has previously worked in STD at both the state and county levels. And Sagat Karki is a health scientist at CDC's Division of STD Prevention, and he began his career at CDC in 2018 as a public health informatics fellow. So Alejandro and Sagat, hopefully we can hear you.
Okay, hello everyone, this is Alejandro Perez. I don't know if Charlie can hear me, but I'm just going to go ahead and talk through while he troubleshoots his speakers. Let's just go to the next slide. Hopefully he hears that. So in the agenda, you see that I'm going to start with some background information on ECR, and then I'm going to talk about our earliest work defining ECR for chlamydia and gonorrhea, as well as piloting those materials. And then Sagat will talk about our wider adoption of that ECR approach, as well as some work that we're doing with PACER, using PACER for ECR. And then we'll end up with some information on various ECR resources that we've put together over the years. Next slide.
Claim from Chaz 277700 AO.
All right, next slide, please. All right, let's get started with the next slide. So I'm sure that everybody here knows about disease reporting, but since it's such an important part to understanding ECR, I'll ask that you humor me for the next couple of slides. So as you all know, various states have laws that define this reporting. These laws may differ from one jurisdiction to the next, but mostly they list reportable conditions. They specify who is responsible for reporting. They outline the kind of information that must be included in the reports and so forth. And it is these laws that give you at the health department the authority to collect the surveillance data that you need to conduct your business. Next. In terms of reporters, most labs nowadays rely on electronic lab reporting, or ELR. It is a very convenient approach, as it is very fast and very easy, both for labs to send and for varying degrees for health departments to receive and process those data. One of the major downsides to ELR, unfortunately, is that the data available in the labs are usually fairly limited. You rarely have full demographic data, for example, and you're missing a lot of the contact information that might be needed by DIS. And there are also never any data on things like clinical data, such as signs and symptoms or treatment. Due to a number of complicating factors, reporting by healthcare providers is largely a manual process. And as a manual process, while it might be practical to report rare diseases, rare events, filling out these reports for high volume conditions like STDs is just not feasible, which is a shame, of course, because providers, while they should have the same numbers of cases as labs, providers, they do have that wealth of clinical and patient information that public health misses out on by not receiving those reports. Next slide, please. To give an idea of the scope of the burden of reporting STDs, you see here, obviously it's 2019 before COVID-19 came, COVID-19 was represented, but you can see how STDs compare to the other most common notifiable conditions of the day. Obviously, manually filling out 2.5 million disease report forms, whether on paper or online, let alone processing them all to health departments, is just not at all practical. And so for that reason, provider reporting is neither widely done nor widely enforced on a large scale. So what are we to do then? Let's go to the next slide. And you can see that just like we have ELR for labs, providers also could use electronic case reporting. As you can see in the slide itself, this is defined as the automated generation and transmission of case reports from electronic health records to public health agencies. There is no single set method of conducting ECR, so while our slides here will focus on some of the approaches that we have used in our division, please remember that other approaches do exist and they're all just equally as valid. Next slide. There are 3 things to consider when developing ECR. The first is when to report. Next animation, please. The conditions that specify when an electronic report is to be triggered may come from CST position statements and may include things such as lab criteria or clinical criteria. The next aspect is what to include in the electronic report. Next. These data, they come from EHRs and can therefore include things such as demographics, clinical information, and test information. Lastly, next, one must consider how the health department will process the data. There is no sense in setting up ECR, for example, just to have you need to print out all those reports and then enter them by hand into your system. So that one's quite variable. Next slide. With those things in mind, let's talk a bit about some of our earlier work with our ECR projects, which ended in 2018. Next. The first thing that we did was come up with 3 scenarios for defining the trigger criteria for chlamydia and gonorrhea. The first condition for creating an electronic case report is for the EHR to list a specific diagnosis code related to STDs. Alternatively, a patient could have a positive result that is specific to a pathogen of interest. And then the third scenario is a combination of a pathogen-specific lab test with a positive result. And then for each of these scenarios, we also came up with a list of ICD-10 codes, LOINC values, SNOMED codes to kind of go along with that. To prepare us for, and then next slide, please. As for the body of the report, we went through data commonly available in EHRs and identified those that were most relevant to morbidity reports established by health departments. As you can see, this might include information on the patient, demographics, healthcare encounters, testing, treatment, and so on, to name a few. Next, please. With that work as the foundation, we then partnered with PHII, the Public Health Informatics Institute, to run a 2-month ECR project in 8 Alliance Chicago clinics. As these clinics were already sending in provider reports with the existing manual process, we then compared data received by the health department via ECR to those received through traditional paper reporting. Next. Here you can see some 2x2 tables comparing ECR to paper reports, both for chlamydia and gonorrhea. As you can see, the ECR reported higher levels of reporting for both conditions, with a 147% increase in chlamydia cases and a 123% increase in gonorrhea cases. Next, please. Not only were there more cases reported using ECR, but the resulting data were also more complete, both of which are important on their own. One of the downsides is that the treatment information was largely missing from ECR for this pilot. This ended up happening because the reports were generated as soon as they were triggered. So they were sent to the health department before patients had a chance to return for their prescriptions. As an aside, while not a direct result of the pilot study itself, we also saw from discussions and environmental scans that there was a lot of growing interest and heat, as you might say, over FHIR, the new HL7 messaging standard of the time. So now I'll turn it over to the author of that pun, Sagat Karki. Thank you.
Thank you very much. Next slide, please. So following the initial pilot to test the feasibility of ECR, we wanted to conduct an end-to-end implementation and expand it to include public health agencies. For this phase, we conducted 2 separate pilots. In Oregon, we worked with OHA, the Oregon Health Authority, and we selected OCHIN as the EHR provider and 3 OCHIN clinics in Oregon. This pilot was conducted for 15 weeks. And in Illinois, we worked with the Illinois Department of Public Health, where Alliance Chicago was the EHR provider, and we selected 8 clinics in Illinois, where the pilot was for a little over 7 weeks. Next slide, please. So So for cases of chlamydia, ELR consistently reported more cases than ECR in both Oregon and Illinois. In fact, in Illinois, ELR reported 100% of chlamydia cases. However, for cases of gonorrhea, ECR reported more cases than ELR in both Oregon and Illinois. But ELR still reported additional cases that were not reported by ECR. Next slide, please. So we also compared the completeness between ECR and ELR. For almost all data elements, ECR provided more complete data. We have highlighted in gray where ECR demonstrated improved completeness compared to ELR. And important examples include medications, symptoms, reason for visit, and diagnosis. As you can see, this was consistent in both the pilot sites. Next slide, please. So to summarize, we learned that ECR provided more complete data, but ELR is still reliable for reporting cases, just not complete information. We also learned that every implementation of ECR needs some degree of customization. There are non-standard codes which are widely used in EHRs, and mapping to ECR standard is necessary. So more importantly, surveillance information systems are not inherently designed to ingest electronic messages, and interfacing platforms become necessary. And FHIR was still generating a lot of interest. Next slide, please. So we move on to PACER, which stands for Public Health Automated Case Event Reporting, and I'll explain how this is different. Next, please. So going back to the anatomy of ECR, we designed PACER as a combination of the best of ELR and traditional ECR. We used a reported ELR to trigger a query. Next slide, please. Removing all the complexities of triggering an ECR. So we leveraged, next slide, please. So we also leveraged FHIR to construct the body of the message. So any information that is predetermined by the public health agency and the participating clinic can be reported. We also designed privacy preserving filters for the clinic to ensure that only relevant information is reported. We learned that with traditional ECR, ingesting electronic messages at public health agencies is a challenge, but PACER client that interfaces with the surveillance system to trigger these queries also consolidates and ingests FHIR-based case reports. Next slide, please. So how is this different? I'll summarize that again here. So using ELR as a trigger to identify a reportable case removes all the complexities of triggering at the EHR. If you can imagine traditional ECR as pushing case reports, PACER pulls case reports. We use clinical quality language to construct queries, and this versatile method allows us to construct public health requests into a standardized logical query, and we can perform multiple queries, multiple pulls over time to receive a more complete case report. Next slide, please. So I'll try to explain why this becomes important. If a patient was seen by a clinician, labs are ordered, but the result is not available immediately. And if the clinician assigns a diagnosis, then the criterion for scenario 1 of the ECR trigger is met, and an ECR is triggered, but without much relevant information. Next, please. So now 2 days later, if a positive lab result is returned and like all 3 trigger criteria are met, and an ECR can be generated. Next slide, please. But we found that treatment information is typically available at a later date. So if ECR was triggered before this time, treatment information not just available on the case report. Next slide, please. So we collaborated with GTRI, that is Georgia Tech Research Institute, to design this architecture and piloted PACER at the Medical University of South Carolina over an 8-week period. And the main goal was to test the technical feasibility of this design. Next slide, please. We found that PACER case reports had a high degree of completeness. We confirmed that ELR can be an excellent method of identifying and triggering case reports. The versatility of SQL can be used to query almost anything. And we designed a filter that prevented unrelated information. For example, diagnosis and medications from 10 years ago are not reported. Next slide, please. So moving on to phase 3, which is the current phase, what we want to call PACER adoption. Next slide, please. So currently we have collaborated with PHII, GTRI, and OCHIN to pilot at 2 public health agencies. We partnered with Houston Health Department and Georgia Department of Public Health, and both the pilots are underway. Next, please. So at Georgia, currently, we're trying to install the PACER client, whereas in Houston, the PACER client has been installed, and we are currently performing some pre-deployment testing. So over the years, we have curated a lot of resources for all these different technologies that you've seen. And we have a website to host all of this information under one banner of STI Connect. Next, please. We also have separate web pages for traditional ECR. Next, please. A PACER ECR. Videos explaining the goal and architecture. An e-learning course hosted by PHII. As well as publications disseminating findings from traditional ECR. And next slide, please. As well as from PACER ECR. Thank you very much. I think we stopped at 3:30. If you have any questions, you can always send us your queries at the email shown here. And thank you.
So hopefully everybody can hear me. Again, thank you for bearing with our little, I had some, looks like some microphone issues or headphone issues anyway. So while I'm going to go back to Robin's section. If Alejandro and Sagar could look at the chat, if there's any questions or issues they want to discuss, and I'll move our slides back, and Robin can catch up and give her presentation. So give me a second to go back to Robin's presentation. So Robin, hopefully you can get started again.
Can you hear me, Charlie?
I can hear you.
Can everyone else hear me? All right, great. Yeah, next slide, Charlie. So what my main update today is just to share with folks, if you haven't already seen or been told, that we have a reconciliation timeline for 2021 STD case reports. So C-cells will begin reconciliation this month, August 2022. And during that time, DSTDP emailed quality reports to all jurisdictions. I know we received ours in New York City. So if you haven't seen yours, please take a look for them or contact your project officer. In August through October 19, that's when jurisdictions will finalize their 2021 STD case data, and they should be using the MVPS portal to review view STD case data. And October 19th is the final closeout date for submitting 2021 STD case data to CDC. So please mark that date in your calendar. This is a tentative, but mid-November, DSTDP hopes to send the sign-off letters for jurisdictions to sign off and finalize their case numbers. Next slide. And then on December 1st, 2020 is the deadline for jurisdictions to send their signed off letters back to approve 2020 case numbers. Another important date to keep in mind is on August 16th from 3 to 4, there will be an eShare webinar covering 2021 reconciliation. So you can use the email listed here, edx@cdc.gov, to be added to the distribution list and be able to attend that webinar. And if you have any questions regarding the timeline, you can contact the email listed here. And I said contact your project officer if you didn't get your quality report, but I didn't mean it. I mean, you should contact STD_serve_inquiry@cdc.gov if you did not receive your quality report. So that is the CDC update for this session. So Charlie, do you want to move on to see if we can get some questions answered?
Sure. Why don't you go ahead and take any questions either on your presentation or on our previous one, and I'll move the slides up and get ready for the New York City presentation.
So the first question in the chat, not related to my audio, it comes from Bob in San Francisco, and he was commenting that treatment information is the most important data we cannot get through ELR and the most important function of ECR, and I would like to hear if that has been addressed. And I think that, Sagat, you might be able to talk about this regarding the PACER. Actually, if you stop, don't stop right there, Charlie. Go ahead, Sagat, if you want to, or Alejandra, if you want to answer that question.
Sure. I think Alejandro has answered in the comment that we did experience the similar issue that he just mentioned, and it had to do with timing. So we are hoping that PACER will alleviate some of that problem.
Thanks. I did not see that he answered that. So thank you for that, Alejandro. Jillian says pregnancy status, begging emoji. And yes, I think that's one of the most important things that many of our jurisdictions want out of ECR. Then we have a question, Lita Jimenez, who is actually going to be one of our next speakers, asks the CQL querying through FHIR, question mark?
So I can talk about the pregnancy one. We are also interested in finding and transmitting and including the pregnancy status in the ECR message. It is very tricky though, because most electronic health records don't have, a single field that gives you the pregnancy status at a specific point in time. So it's something that we're working on. It's a bit of a struggle. The idea would you'd have to check in several parts of the medical record, and then you have to account for timing as well. If they were pregnant, before or after the diagnosis, that might not be relevant to you because you want to know the status at the time of the diagnosis. So it is pending, and we're much more confident about the ability to bring in treatment information. with PACER, unfortunately, but thank you for bringing it up as a reminder. Same thing
Okay,
with
so I would say, Robin, let's move to our next, the New York presentation. Then if we have any time left, we can cover any questions from New York and go back. So if you want to introduce our next speakers, Robin.
Will do. So thank you, Alejandro and Sagat, for those presentations. Now we're going to hear about the New York City ECR project overview, and there will be 4 speakers, and I'm going to just give a brief introduction for each of them right now. So the first person who's going to be speaking is Aruna, and she is the project manager on the ECR onboarding, data quality, and assurance project for the New York City Department of Health and Mental Hygiene. She provides project management, administration, and oversight support for ECR onboarding and data quality assurance process. And she's previously supported Enhanced Meaningful Use project for administration of the New York Medicaid EHR incentive program, supporting project planning and oversight activities for electronic interoperability. Next will be Lita Jimenez, and she is a business analyst on the ECR onboarding and data quality assurance project. Lita utilizes business intelligence to enhance surveillance applications and streamline data integration processes. She has also supported Enhanced Meaningful Use project for the administration of the New York EHR incentive program to facilitate the program onboarding process and quality assurance of EHR data submitted by healthcare organizations for the immunization registry. Ram is an informatics and business analyst on the ECR team, and he leads the outreach, onboarding, and application enhancement support activities for the electronic case reporting registry. And then finally, Lakshmi is an informatics analyst on the team, where she leads the data quality assurance analysis activities for ECR. Lakshmi has previously supported Enhanced Meaningful Use for the New York Medicaid EHR incentive program, and has done data QA activities for syndromic surveillance registry reporting measure. So that was a mouthful, and I'm going to turn it over to our speakers and let them do the talking. Thanks so much.
All right, thank you so much, Robin. Good afternoon, everyone. This is Aruna. So for today's agenda, I will provide a brief background on case reporting, discuss benefits to electronic case reporting, review how the different systems, AIMS, and RCKMS fit into the overall ECR process for data flow, discuss initial planning efforts for setting up the onboarding and data QA process for ECR at New York City. And then the team will provide an overview of the ECR onboarding, data QA process, and then provide a snapshot of our ECR dashboard, a visualization tool to inform our QA process, as well as reporting ECR metrics. Next slide. So healthcare organizations historically are manually reporting notifiable disease or conditions to New York City DOHMH. Reports from the healthcare organization using these manual reporting methods don't always have complete or comprehensive data needed for surveillance management activities. The Digital Bridge Initiative provided an interoperable, scalable, and multi-jurisdictional approach for transmission of electronic case reporting, which laid the foundation for bidirectional exchange of information. At this time, healthcare organizations are onboarded for ECR in New York City are continuing with parallel reporting, meaning they are reporting manually as well as reporting via electronic case reporting. In the future, electronic case reporting is intended to replace manual reporting as a solution to an automated, comprehensive form of reporting. So there are numerous benefits for electronic case reporting. It supports faster identification of healthcare needs to better target populations in need of public health interventions. It reduces the burden of reporting for healthcare organizations to public health agencies without disrupting their clinical workflow. It helps to reduce manual case reporting process while also supporting reporting of more comprehensive data. It fulfills the CMS incentivized program rules for healthcare organization and provided reporting requirements mandated by the New York City Health Code. Next slide. So this diagram displays the data flow for ECR, starting from healthcare organizations to AIMS and then to New York City DOHMH. In the swim lanes, we have the healthcare organization, the decision support intermediary AIMS, RCKMS, and public health. So the Association of Public Health Laboratories, APHL's informatics messaging system, known as AIMS platform, validates and routes data to public health from the provider's EHR system. The platform facilitates the health messaging and has a shared service to support the transport, validation, and routing of electronic data. RCKMS is the Reportable Conditions Knowledge Management System, which is the authoring interface for public health agencies to add and manage their jurisdiction reporting criteria. So here, public health agencies define what is reportable. The public health agency defines the reporting criteria, provides the trigger codes in RCKMS, and then the reportable conditions trigger codes are imported into the EHR. Healthcare organizations, if you want to go back, I'm sorry. Healthcare organizations enters patient information into the EHR. If the information matches the triggers for the reportable condition, then an electronic initial case report is sent to AIMS. AIMS validates the case reports and compares it to the reporting criteria in RCKMS to determine if it matches the public health reporting rules. It then creates a reportability response, and both the electronic initial case report and matching reportability response is sent to the public health and to healthcare organizations. So the reportability response acts as an acknowledgement that the reporting was carried out correctly and a case report was triggered. It also contains the reportability status of the conditions. And just as a note, electronic case reporting has two reporting standards that differ from the standards used for electronic lab reporting, syndromic or immunization reporting, which was HL7 2.5.1. For ECR, the reporting standard is the new HL7 clinical document architecture, which is the standard XML file format for clinical documents that contain the public health case reporting information. And then the alternative future reporting standard is the HL7 FHIR standard, which is the fast healthcare interoperability resource. Next slide. So in July 2019, as part of the Digital Bridge initiative to provide an interoperable platform for transmission of case report, New York City DOHMH onboarded and piloted a site for electronic case reporting. We were looking at operational planning for onboarding and data QA and built the infrastructure to process incoming data. As of 2020, COVID-19 reporting became high priority nationwide for ECR. Epic sites were prioritized, Epic vendor being the first implementers of electronic case reporting. We developed ECR outreach process and procedures and data QA planning checklist. We developed outreach communication and started onboarding and started conducting outreach to onboard healthcare organizations for ECR. Once onboarded, we started performing QA analysis on the incoming data. Our approach was to identify measures for data completeness and accuracy, which involved determining if the data is consistent and complete, identify what data elements or values are missing, determine if fields are populating as expected, checking for invalid values. We also needed to account for troubleshooting message failures and connectivity issues, ensuring that files are routed correctly to New York City via the AIMS platform, and put measures in place to monitor routes or transmission failures. We also looked at system processing and data mapping, which included reviewing recommended values for XML file structure, comparing the values from the XML against the database values, and ensuring that files are processing and transferred into the ECR database. We also started performing data quality assurance and monitoring. During this time, we identified and developed tools to enhance quality analysis of the data. That included developing an ECR dashboard, a visualization tool to inform our QA process as we work with healthcare organizations to identify gaps in reporting for data consistency and accuracy. Thank you. I will now hand it over to Ram to provide an overview of our outreach process.
Thank you, Rita. Good afternoon, everyone. So we will now discuss the ECR onboarding lifecycle. Next slide, please. So the ECR outreach process kicks off the life cycle. So New York City current onboarding involves prioritizing outreach for COVID-19 reporting. When this project initially started, we were conducting outreach to healthcare organizations, providing information on the ECR initiative, and requesting the healthcare organization's EHR information. However, as the project evolved, we have streamlined our communication to also include requirements for onboarding, which can be found on our New York City ECR website. We're requesting healthcare organizations to specify their EHR systems clinical requirements. We provide chapel instructions for healthcare organizations really to determine the EHR product certification. We have also updated our outreach language to include the final rules for the CMS program, which is the merit-based incentive payment system, and the Medicare Promoting Interoperability Program. We are also conducting outreach to EHR vendors really to gain insight on the ECR implementation status. So far, the impact of our outreach has been we are currently in the process of completing on all electric healthcare organizations. Oops, sorry, Robin. We have been able to get non-registered healthcare organizations engaged for ECR, engaged with EHR vendors, and can you move back one slide, please? Sorry, Robin. Yeah, just to recap really quick. So the impact of our outreach, we are in the process of completing onboarding for all Epic healthcare organizations. We have been able to get non-registered healthcare organizations engaged for ECR, engage with EHR vendors, and we have provided steps to keep healthcare organizations engaged based on the ECR Confluence website updates. This is all for the ECR outreach. I will now hand it over to Lita, who will discuss the ECR onboarding lifecycle and touch on the QA process. Thank you.
Thanks, Ram. Good afternoon, everybody. So just like we streamlined our outreach process to support the programmatic changes and public health needs, we've also streamlined the ECR onboarding process by identifying key milestones and providing support for each of the onboarding phases. So the onboarding life cycle begins and ends with the New York City ECR team, starting, as Ram mentioned, with that initial, within the initial discussions phase, the outreach to engage the healthcare organizations and set up an introduction call to let them know more about ECR at New York City, and then have, when their EHR vendor product is ready and contracts are signed, they can move on to the introduction implementation call with the CDC ECR team. Will there solidify next steps for implementation and join a cohort call to discuss technical details and strategize implementation for the testing phase. During the testing phase, the CDC ECR team will be setting up connectivity to the AIMS platform and testing XML content for validity of required fields. The ECR New York City team will provide support throughout the process if the healthcare organization needs to be re-engaged, as they sometimes might not make it through quickly through that testing process. During the production readiness phase, the CDC ECR team will reach out to confirm that all testing activities were completed successfully by the healthcare organization and ask us to confirm if we received that production level data to coordinate that deployment. Once the healthcare organization deploys, their data will be reported to our pre-prod environment, and we'll send an outreach to engage the healthcare organization in our last phase of the onboarding process, the New York City ECR certification process. During the New York City ECR certification process, the ECR QA team will be engaging with the healthcare organization, setting up bi-weekly calls in order to close the gaps in New York City production requirement. The healthcare organization will be deployed to production when all ECR certification requirements are met. By streamlining the onboarding life cycle, we've been able to meet the milestone of onboarding 45% of hospitals within the New York City jurisdiction, enabling also the New York City team to easily identify opportunities for onboarding and engagement to support to ensure consistent, successful ECR implementations. Next slide. So just like with the outreach and the onboarding, yes, we've also optimized the ECR QA process. As Aruna mentioned in the beginning of our QA process, we had one pilot location onboarded and the process was manual. It was limited to one file per review since it was an extensive manual process. After onboarding more healthcare organizations, we quickly identified the need to build tools to efficiently identify issues on a higher volume level, both internally and externally. We found that in order to build these tools effectively, we needed to become stewards of the ECR HL7 specification for the CDA as it differed from the HL7 251 standard. So the New York City team became stewards of that new HL7 standard. Solidifying our HL7 CDA knowledge enabled us to automate our foundational tools. And then we developed a QA report template and customized Tableau dashboards that allow the team to perform quality assurance across all reporting healthcare organizations on a high volume of data in a monthly time base and a short amount of time frame. Our ECR QA process provided insight on internal and external trends of data quality, identified high priority data elements to understand what was being reported completely versus what was being reported validly. And more to talk about the dashboards that were developed for the ECR QA process, I'm going to hand it over to Lakshmi.
Thank you, Lita. Just making sure if you guys can hear me clearly. All right. Good afternoon, everyone. As Lita mentioned, initially we faced some issues. We faced some challenges tracking the transmission and monitoring the data quality. In order to overcome the challenges, we adapted and built multiple dashboards. The main objective of building and using the dashboard is to track file transmission and support analysis on the data reported by the healthcare organizations. As we started incorporating the dashboards into our workflow, our QA process is now more streamlined. With a few selections, we are able to filter and view required information. With the usage of dashboard, it is easier to track the key prioritized metrics. Reports are automated, so it is sent out to the contact based on the user requirements and on specified schedules. Also, we are able to set thresholds on to trigger alerts when the data goes below or above the set threshold. We have multiple views which serve various purposes, such as monitoring the file transmission, generating the reports for the internal surveillance teams, and we have dashboards which are focused on quality assurance. Next slide, please. Thank you. As you see on the left side of the screen, this is a view from our transmission dashboard. This helps us to monitor and identify any drop in the file volume from the healthcare organization. Using this dashboard, we monitor file transmission on daily and hourly basis, which in turn is helpful in calculating and identifying the average volume. With the help of this, we are able to set the threshold to identify any drop or spike in the volume of EICRs. Recently, using this dashboard, we were able to identify missing file transmission from one of our healthcare organizations. This helped us to troubleshoot the issues with the healthcare organization and APHL, and we were able to backfill the data at the earliest. And as you see on the right side of the screen, this is a snippet from our weekly report view. This dashboard includes patient demographic information, count of reportable conditions, and the percentage of data reported by the healthcare organization that are identified by New York City surveillance leads. This helps us to keep New York City internal surveillance teams and the healthcare organization informed on the data quality, especially on the demographic related information, which plays a vital part during the COVID outreach. Next slide, please. As you see on the left side of the screen, we have a dashboard which is mainly focused on supporting the QA activities. In this dashboard, it contains the information like the reportability, which is a percentage of data reported, and validity, which helps us to identify what percentage of reported information is compliant with the standard values. We have set a threshold of 80% to be compliant with the data quality reporting standards for New York City. However, this threshold is subjective to the data element. For instance, we do not expect smoking status or travel history to be 80% reportable. Using this dashboard, we are generating monthly reports and engaging with healthcare organization to communicate, troubleshoot, and discuss any issues, and to support improving the data quality reporting. As we roll to the right side of the screen, we are dynamically updating our dashboard according to the need. With this monkeypox and orthopox reportable cases dashboard, we are able to track the number of monkeypox and orthopox conditions reported across New York City. This helps New York City surveillance needs to further analyze and investigate the cases. Next slide, please. So in preparation for expanding the reportable disease scope, we built a dashboard to monitor the reportable conditions that are reported to New York City DOHMH. This dashboard allows us to track when the healthcare organization begin reporting a specific condition, as surveillance leads are continuously authoring new conditions. Also, we are continuously streamlining our dashboard to be more efficient and adding additional views to support ongoing surveillance needs. With this, we conclude our presentation and open the floor for any questions. Thank you.
A great presentation from our New York City partners, so thank you. Robin, any questions you noticed or any comments in the chat that we should talk about?
Well, I did want to say that Aruna posted an email address, which is eicr@health.nyc.gov, if anyone has any particular questions about the New York City implementation. Also, Laura Cohn has posted some information as the CDC ECR program lead. And so I think folks may want to check that out, as well as there's an email address that says ecr@cdc.gov if folks would like to get more information on that.
Great. So I know we're out of time, so I won't take too much time. First of all, thanks everybody for bearing with our technical issues, or really mostly on my end. And I think in true surveillance fashion, we came through, we adapted, and we overcame. So we would like a little bit of feedback on this webinar. We hope the information, the topic, and the information presented was useful to you. So I guess if this is the wrong poll. So let me launch this just to give us some feedback on how useful this presentation was to you in your program. You could take out a second. So again, just to summarize, we will be posting a copy of this presentation and the slide set up on the NCS website probably within the next week. And we'll also be sending out some information on how to join and access the STD surveillance and informatics communication and resource sharing channel on my NCSD, so stay tuned for that. If we have any last minute questions, feel free to take yourself off mute and ask them for any of our presenters. If you have to run and leave, we appreciate your time. We know how busy everybody is. We get slammed with COVID and now monkeypox, so we know everybody is just really responding. Really hats off to everybody for all your work and staying true to what's important, and surveillance is definitely important. So Thank you from NCSD. Any closing remarks, Robin?
No, I just wanted to, thank in particular my colleagues at New York City for jumping in and sharing their work, as well as thanking my colleagues at CDC for also sharing their work, particularly given this, really important and timely topic. So thank you.
Great. So we probably will have some user group meetings in the fall, and then probably our next informatics will either be late fall, early winter. So stay tuned for that, and we will be sending out our information on that. So again, thank you everybody who's joined us, and thanks for bearing with us. So have a great rest of your afternoon.
Bye, everyone.
Thank you.